Cancer Roundtable, and I will serve as today's moderator along with Courtney Van Ord, who will take over during the Q&A portion. Welcome to the third webinar of our three-part series on self-collection. Today's talk is entitled HPV Self-Collection Testing Implementation. We have a great webinar in store for you today, but before we begin, I'd like to address a few housekeeping items. The webinar today will be recorded, and the link to view the recording and a PDF of today's slides will be shared with all who have registered. In addition, the recording link will be posted on our website in the next few days. If you have any issues during today's webinar, please use the chat. If you have any questions for our presenters, please use the Q&A. To ensure there are no disruptions during the presentation, all participants have been muted by the host. And to ensure that we have sufficient time for Q&A at the end, we will be sharing the full panelist bios in the chat. Since this is a continuation of last month's webinar, we have the same speakers presenting. I'm going to provide a quick introduction, and you can read their full bios in the chat as mentioned. Today we have John Lynn. John has worked for over 20 years in the cervical cancer-related study and clinical trial space, managing large NIH and industry-sponsored projects, and specializing in HPV testing and cervical cancer screening. John is joined by Sarah Zumbido, a registered nurse and EHR support analyst at Community University Healthcare Center, a federally qualified healthcare center in Minneapolis. And last but not least, Dr. Carolyn Hawley, a family physician and medical director at HealthPoint Community Health Centers in King County, Washington, is with us today. Let's go ahead and turn things over to John.
Thank you, Kathy. So today I'll be talking about key considerations for implementing HPV self-collection. And each health system and even clinics within systems has widely varying resources, capabilities, and workflows, so including QI practices. So today I'll be talking about base tasks and broad change management or QI recommendations. And the objectives today are to just to make sure that you understand key considerations for implementing HPV self-collection. And number two, to understand the potential challenges and successes from real-world implementations, where you'll hear from a couple case studies. And also, at the end, hopefully you'll feel ready to begin or refine your HPV self-collection implementation at your health system. Next slide. So before we begin, I'd like to ask everyone to complete a short poll on your current status of implementing HPV self-collection and your general implementation support needs. And this will help us identify what that landscape is like there and what other support we should try to be providing. Okay, so let's get started. Next slide. On this slide, you'll see a list of implementation steps that should apply to all health systems. And I'll talk through specific tasks within each of these steps that are applicable to all clinics for HPV self-collection. And as I go through everything, don't feel overwhelmed. You already offer cervical cancer screening, and this is just another specimen collection option. There's no perfect implementation that'll get you to 100% screening rates. HPV self-collection is not a magic solution, but rather is an additional screening option that can increase your cervical cancer screening. And ultimately, just remember, the best workflow is the one that you can deploy. Next slide. Okay, before I get to those steps, there is kind of a step zero of your readiness is I want to go through critical things that you absolutely must have ready before you begin. I did cover these in the past prior webinar, but I'm reiterating for those that didn't attend, since it absolutely cannot be overstated. The first is lab capacity. And this is just to make sure to confirm with your lab that they offer it and most importantly, the capacity to test it. You can offer it, you can't really offer it if you don't have someone to test the specimens. So the next one is metrics. And the answer on this, short answer is yes. And I'll just go briefly on this. Basically, it's a new collection method with the same CPT for HPV testing and ICD for screening. And specifically, HEDIS already explicitly added in 2025 updates that member-collected specimens are included. And UDS has a draft update explicitly clarifying that member-collected is included as well. And for those that aren't aware, the Women's Preventative Services Initiative guidelines came out last week, and they do recommend self-collection as aligned with the draft USPSTF guidelines. And reimbursement, again, the answer is yes, since you're using the existing CPT codes and ICD codes, and it's consistent with metrics. Okay, so let's get to implementation now. Next slide. So the first step is convening a team. And this is pretty slim, but these are key things. These are key folks that you should engage before you begin implementing. And the key members are, the first one is, this may be a little obvious, but you should try to engage all stakeholders. And this means throughout the whole process of your workflow that offers cervical cancer screening. And another next person is the women's health person team that you absolutely must include. And this is absolutely critical, since unlike your existing cervical cancer screening collection methods, a small proportion of those that are HPV positive and other high-risk positive in particular, they will need a second visit to complete screening and to risk stratify the individual. So if someone is other high-risk positive, they're not done with screening. They need to come in for a PAP. And the last person, which should be obvious, is the EHR analyst or whoever builds your orders. And this is naturally absolutely necessary because you need to create a new order and you need to make changes to your existing EHR processes. So next slide. So the next step is assessing your current workflow. And I always recommend that folks do this immediately as your first step after you've assembled your team. And here you see a sample swim lane diagram for just an encounter where a patient presents. So I recommend folks assess the full workflow from identifying patients that are actually due to also abnormal follow-up colposcopy treatment and monitoring and metrics. And this doesn't have to be done with a fancy tool and like a sophisticated swim lane diagram. It could be just a simple list. It could be hand-drawn diagrams on paper. But I do recommend that you assess your workflow as a separate step, because it's not just the tasks that are being done, but it's also who is involved. This could be medical assistants, nurses, your front desk, and you may need to talk to other clinic members that you identify during this workflow assessment. And all these team members that you identify when you assess your workflow are really important stakeholders, which you should engage and potentially include in your QI team. Next slide. So now that you've assessed your workflow, now you need to modify it. So in the above example, the dark blue boxes are existing workflow, and the light blue boxes are modifications that you might need to make. So I split this out to two steps of assessing your workflow and modifying your workflow, because I think it's very important to identify everyone that you need to engage to find out what modifications might impact your entire workflow. Next slide. So some key steps in modifying your workflow, first of all, is naturally meet with your team to review the workflow. You'll need to create an order and all that, and so you definitely want to make sure that everyone is there to make sure who is going to be affected. And so next is getting your EHR set up. You'll need to obviously create an order and connect it to your testing lab, but some key recommendations that I make from helping other FQHCs is that make sure you rename the order clearly to indicate that it's for HPV self-collection only. And if you're pulling from a lab test catalog, it's usually not an ideal name, as you're probably all familiar with. And so a simple edit that I sometimes recommend is that you just put self-collect, maybe in square brackets or something in uppercase at the beginning of the order name. And when you do create the order, also make sure that it's also in any existing cervical cancer screening order sets or groupers or groups. And what this does is this will make it automatically be included in any cervical cancer screening metrics and reports, well, in an ideal case. And the reason for that is usually reports and metrics and things like that and population health dashboards do pull from like the groups of all the tests. And also don't forget to update any system-wide or shared preference lists that you have for orders. And if clinicians maintain their own lists, do remember that you need to notify them that they should be updating their list to include this new order and the correct order to include. And if you use macros or smart tools, make sure to update those for cervical cancer screening. And this might include visit documentation, results interpretations, letter templates, etc. And so the other thing you need to do is make sure that you get your billing and ordering team set up. There aren't really any changes here since you're using the existing CPT and ICD-10 code, but it's just to notify folks at the order level in your EHR, that there's another order coming along, but it's using existing codes. And then, of course, there's modifying results, communications, and reports. And this could include patient results letters and due reminders for tracking patients and reporting and monitoring. And because it is an additional change, I do always want to remind you that, there is that small proportion of other high-risk positive patients that will need an additional PAP visit to complete screening. All the other management pathways are the same. So, some tests go to colposcopy, some go to surveillance, and some go back to routine screening. And then, of course, the last thing is just identifying all the resources that your patients might need. For example, you might want to consider offering translated patient-facing materials, video instructions, and other materials for low literacy populations for the specimen collection in particular. And as I said before, I think you should really leverage your existing materials. And for example, in this case, you could leverage your existing vaginal collection for chlamydia and gonorrhea. Next slide. Okay, so the next is training your staff. And this slide is a little sparse, and I won't go into detail here since all of you have some preferred way to train staff on a new test or workflow. But I do just want to remind folks to think of all the clinical staff here. Not just clinicians and MAs, but there might be workflow. During your workflow mapping, you may identify additional touch points, and that could be people, if you have separate people that are rooming or the front desk and billing and all of those folks. Next slide. So now that you've created your workflow and trained everyone, it's time to roll it out. So I recommend really not too many recommendations here. One is I just recommend that you perform an end-to-end test of your entire workflow. And this can be something really, really simple if you don't already do this, where you start from the very beginning, like you mock a patient offering, could be just you to yourself doing it, walking into the room. You label and route a sham specimen to the lab. You can generate a results letter, and you can make sure that it shows up in all the abnormal follow-up and resulting tracking. And then, of course, the last thing is just start offering it. And when you do, I do recommend also that you do a phased rollout. If you're just one clinic, start with one clinician. If you're in a larger system, start with one clinic and then roll it out. And then do a PDSA cycle. Next slide. Okay, so now that you're offering it, you need to monitor your progress and perform any mandatory reporting like HEDIS, UDS, or BCP. So the important reminder here is that you should adapt any existing tracking methods. And I can't overstate this enough is just don't forget that this is a new additional collection method. So don't try to be changing your entire cervical cancer screening workflow. That's just more training, more things to break, more things to program and everything. There are no new results or results types or components to monitor here. It's still just the same HPV test. It's just a new way to collect the specimen. And as I mentioned before, besides that small proportion of other high-risk positives that need additional PAP, all the management pathways are the same you could use the ASCCP app or website to manage. And so in this slide, I'm just listed some monitoring things that bear noting. So for the HPV self-collect results, the first is screening participation. And a simple way to do this, if you don't already have a report, is just to run UDS or HEDIS or any existing metrics reports. And the next is within the specific results, abnormal results. So abnormal rates, other clinics have generally observed about 3% that are HPV 16-18 positive, about 7% that are other high-risk positive, and less than 1% that are unsatisfactory. So if you see higher than expected unsatisfactory results or other ones or lower proportions, check with clinic staff about it and see how you might be able to improve. And so the next group is other high-risk positive. And so this is the important group where you will need to make a change since the patients will need to come in for a separate PAP visit to complete screening. So there's no currently defined target requirement for adherence to this, but a reasonable target goal is 75% within 90 days. And this would align with the National Breast and Cervical Cancer Early Detection Program, colposcopy adherence rates. And other clinics have generally observed about 70% abnormal PAP rates as well, just so you know. And for unsats, the easy solution is just to include them in your existing unsat tracking. You already have unsat results from PAPs and HPV, and so just include those in there. And since you might be reaching more overdue individuals or folks that haven't participated in screening, I do recommend that you do monitor your adherence here, because you really want to find comparable rates as your other screening for folks coming back if they have an unsatisfactory results. And the last group is the HPV 16 or 18 positive. And these individuals, they go right to colpo. And so they should just be added to your colpo tracking. And as a reminder, again, like I said before, the BCP target goal is 75% within 90 days. So if you add them to your existing report, I do recommend that you break out self-collect versus clinician collect, because like I said before, you may be reaching folks that are, that you may have a harder time getting back for a diagnostic follow-up. So that is, next slide. So enough from me. So now let's go to a couple FQHC to talk about their experiences offering self-collect. And first up is Dr. Carolyn Halley, and they're the medical director of HealthPoint CHC in the greater Seattle area. Next slide. Carolyn.
Hi, everybody. My name is Carolyn Halley. I'm a family doctor and medical director at HealthPoint, which is an FQHC in King County, Washington, outside of the city of Seattle. And I was also the organizational champion for the Step 2 trial last fall. Next slide, please. So HealthPoint's a medium-sized FQHC with 13 primary care clinics. The slide says 12, but we just opened one. And 6 school-based clinics. We have a typical FQHC patient population that's 99% low income, 2/3 Medicaid. Our patients speak over 70 languages, and we serve about 70% of newly arrived refugees in King County. Next slide. So our HPV self-collect rollout has been in 2 stages. We joined the Step 2 trial in 2024 with the planning year with University of Washington and Kaiser and University of Chicago. And then we started offering HPV self-collect at 2 of our primary care sites in August of 2025. There's also a home kit arm of the study through 2 of our MCOs. We used the University of Washington lab during the Step 2 trial for 2 reasons. One, since home kits aren't FDA approved, we were required to use the UW lab for this arm. And during the planning stages, it wasn't clear if LabCorp was going to be ready to offer self-collect in time for launch. Then we took what we had learned from the early stages of the trial and folded that into our full organizational rollout that happened in November and December. At that point, we switched to using LabCorp for processing the tests as there was no longer a home test arm. And the interface between the UW lab and our own EHR was never optimal and involved a lot of manual work for our MA staff. And we also developed our own metrics, and I have a slide about those later. We don't have any data back yet because this is all really new. Okay, next slide. So overall, the project has been really successful. It's gone really smoothly, and that's certainly partly a result of the careful planning leading up to the trial and the learning we got from those first couple months at the trial clinics. So some wins, we've had consistently enthusiastic providers. We've never had a problem getting providers on board, quite the opposite. Actually, we had a couple of providers who saw the FDA approval back in 2024 and tried to order self-collect before we had even launched, just using the traditional PAP broom. So anyway, people have been really enthusiastic. We also had a Epic physician builder on our team who built out an order set for cervical cancer screening that launches directly from the cervical cancer screening care gap so that it's easy for providers to order the right test. And the self-collect option actually only even fires if the patient is between 30 and 65 years old. We did training on self-collect at an all-provider meeting last summer so that everyone had the basic information and anticipated the stages of our rollout. And then we developed education modules for providers and then separately for MAs that were shown at site meetings before rollout at any given site. One really important thing is that we included medical assistants in the workflow. So we developed a daily workflow in which providers identify patients that are due for cervical cancer screening and eligible for self-collect during pre-charting. share that with their provider in the morning huddle. And then the MA would go in during rooming, let the provider know that they're due for cervical cancer screening, that there's a new testing modality, and gives them the handout that we developed on self-collect to read while they wait for their provider. This has allowed us to perform cervical cancer screening for patients who were due and eligible at essentially any visit, including visits for acute or chronic conditions, similar to our flow for colon and breast cancer screening. And this has many benefits, including increasing screening rates, reducing the need for patients to make additional appointments to have a pelvic exam, and increasing access to care overall through the opening of visits that would have otherwise been scheduled for that path. We also developed an FAQ for providers during the step 2 trial that then we were able to use during our full rollout that answers questions like, what if the patient wants me to do the vaginal collection rather than do it themselves? Why can't a patient do the self-collect if they're pregnant? How seriously do we need to take the, quote, nothing in vagina for 48 hours rule? Can someone take the test home and perform it there and bring it back? Next slide. Our challenges included that most providers at HealthPoint were still doing co-testing rather than primary HPV testing for cervical cancer screening. So we made the switch to primary HPV and vaginal self-collect at the same time. So we had more questions than we would have if we'd already had an established understanding about primary HPV as the main cervical cancer screening test for patients over 30. We also started vaginal self-collect at the same time as LabCorp did, basically. So there were a few small hiccups there, and I'll talk about one in a minute. Another challenge has been that there continue to be mixed messages about when to offer vaginal self-collect. The FDA approval, as you probably know, states that self-collection should only take place when the patient and healthcare professional have determined that it is not possible for the clinic to collect the cervical specimen. We decided to interpret that language broadly so that we prioritize getting screening done, knowing the evidence for self-collect is very strong. There are also mixed messages about the self-collect follow-up interval. As you know, the ASCCP and then the American Cancer Society guidelines state that cervical collect is preferred and reemphasize that by having cervical collect follow-up interval at 5 years, but vaginal collect at 3 years. And then the USPSTF draft recommendation and now HRSA give parity to both tests in terms of preference and follow-up interval. Another challenge has been that LabCorp is using a vendor to actually put together the flock swab, the thin prep, self-collect instructions, and the specimen processing instructions into a bag that then they send to us. And this, it makes sense for the tiny minority of people who will go to a LabCorp facility and do the tests there, but it doesn't make sense for the vast majority of tests that are being done in a clinic where we actually need the swabs in the room and the thin preps in the lab. So unfortunately, right now, LabCorp is paying to put these kits together, and then we take them back apart when they send them to us. And then for us, unfortunately, we still don't have a mechanism to track patients who have had a positive HPV result and need to return for colposcopy or cytology. This was already true before self-collect, and if anything, launching self-collect has put some fire under the need to create these processes. Next slide. So metrics that we intend to follow include probably what you would expect: cervical cancer screening rates before and after self-collect rollout, percentage that were self-vaginal versus cervical collect. We want to look at some demographics like refugee and non-English speaking rates of vaginal versus self-collect, and then gender diverse patients with a gender dysphoria diagnosis. And then, of course, following up on what are rates of return for follow-up after an HPV positive result. Next slide. So here you'll see our self-collect information sheet for patients and low literacy instructions. These actually came directly out of the step 2 trial, and we modified them a bit for our full rollout. But I have to give credit to the study for helping to create those. So that is all of my slides.
Thank you so much. So hello, everyone, and thank you for having us here today. I am Sarah Zimbato, and I'm an EHR support analyst and nurse informaticist here at the Community University Healthcare Center, or COOC, as we go by. We're a single site, federally qualified health center located in South Minneapolis in Minnesota. We're one of a handful of FQs nationally with a co-applicant status, and ours is with the University of Minnesota. So a little bit about COOC. We employ about 145 staff, and last year we hosted about 185 students and learners, so more students and learners than staff. Most of our learners come from the different schools from within the University of Minnesota, such as the School of Medicine, Nursing, Dentistry, etc. Next slide, please. Or actually, stay right here. In terms of patient volume, last year we saw nearly 12,000 patients through approximately 49,000 visits and have an operating budget of $25 million. Ocean Epic is our EHR. Ocean is a nonprofit vendor who has one instance of Epic that is shared among many different organizations in the safety net and has key features to support community health centers such as our federal reporting. This is a way for safety net clinics like us to have access to the power of Epic. However, it is different from larger academic medical centers or big integrated health systems that may have their own instance of Epic. Next slide, please. So we've touched on this, but to highlight a bit more about our clinic, our payer mix is heavily Medicaid, uninsured. Only about 9% of our patients have private commercial insurance. And language, as well as race and ethnic diversity, is another piece that makes COOC unique. Greater than 50% of our patients prefer their care in a language other than English. And last year, we recorded 57 languages spoken, with the top 3 being English, Spanish, and Somali. As mentioned, we typically have more learners come through COOC than we even have FTE of staff. And a subset of those learners are also required to complete QA and QI projects as part of their practicum. Learner projects are meant to align with our strategic initiatives and quality goals and are often ways by which we can pilot some projects with limited resourcing. Our HPV self-swab was a combination of a learner project aligned with a request to participate in a research study, which was known as the ISHBAR project, focusing on HPV self-swab, both linked with improving cervical cancer screening as the QI topic. COOC was one of 3 clinics nationally who first offered HPV self-swab as an option for patients beginning back in 2023. Next slide. All right, so from plan to practice. So for most learner projects, we typically create a small project team where the learner and preceptor act generally as the project managers and have access to support from technical and clinical subject matter experts. And this gets all overseen by our quality director. However, you don't have to have learners to do this. Organizing a project team, even on a small scale, makes it doable. For our self-swab implementation, the learners supported mapping of the new workflow, updating the procedure and protocol, setting up targeted communications and training, which included actually simulations for all of our clinic staff, so providers, nurses, CMAs, and facilitated the launch of the process. We had access to patient-facing materials in multiple languages, which was super important for us, and that came from the research study. I was the RN and EHR lead at the time, and I managed lab build with our vendors and tracked results with the support of our chief clinical officer. This included results review, communication, direct provider feedback as we ran across inappropriate use of the swab. And as part of the end of project summary evaluation, the learner provided the COOC team with lasting feedback on next steps and the foundation to keep improving the process as it was handed back to the COOC team to continue. On this slide, you see a picture of one of the posters that actually was hung in our provider and nurse rooms as a reference to the process. And then on the next slide, pop over, some additional examples of the materials from the project. So the mapping of the workflow, a slide from the training deck regarding like the simulation. So each group had a training, had simulation and support in learning the process. Our protocol, and then just an example of one of the materials in another language that was available. Next slide, please. So through our process and many cycles of PDSAs, we focused on being very solution driven to overcome challenges as they came up. So in healthcare, there are so many guidelines, things to remember, and many of our providers and residents have had gaps in knowledge of just like the cervical cancer screening, treatment, surveillance continuum. So our RN team has actually worked to become the subject matter experts with the support of our chief clinical officer. They really work to the top of their scope. Providers can ask for support when determining when to screen, what options they could offer their patients. And all of the results are actually mapped to drop into the RN in-basket pool. And the RNs have access to the ASCCP app or website to support the result review. And then they'll engage with our CCO for questions, scenarios that need additional review, etc. Our current RN supervisor additionally provides initial orientation to new providers about our process and attends provider meetings to provide updates, training, either on an annual basis, but as needed as well. And then the RN team is also responsible for getting patients back for follow-up, such as for colposcopy or referral out for further treatment. Initially, the EMR tools like the cervical cancer tracker, health maintenance, and Epic weren't quite fully aligned because we were doing this before we were here today with the guidelines. So we did have to be really creative with our documentation, making it easy for providers to know what was needed and when. And then result documentation and communication were standardized as well. And then now we're seeing new tools and resources in the EMR catch up, actually, even in just the last few months. And something that could always happen, one of our kind of like snafus during the middle, was that test code changes can happen. We have a unique lab that most folks might not have, but here in Minnesota, Fairview Labs is our reference lab. And a little over a year into the process, they changed just all of their PAP and HPV test codes. And we had to kind of treat it like a little mini project in preparation of that change, because PAPs and HPVs are just high enough volume for us that even a week or two of results not filing in the chart can create quite a backlog. And then having just a process for how you manage that, and being prepared to update reports, result mapping, all of that is extremely important. And then with all this work, we've continued to just refine our workflows, learn from it, continue to engage with our staff, and improve our quality metrics and patient experience. So prior to 2023, we were around 39 to 42% of our patients screened overall. And we've had incremental improvement over the past few years. And at the end of 2025, we're sitting around 52%. So we've seen significant increase, which self-swab is not the single solution. Self-swab didn't do all of that. But it is another option or tool for patients who today may have continued to stay unscreened if not given the choice. So that's where we're at. Thank you.
Excellent. Thank you. So just a reminder, if you do have questions, please enter those into the Q&A box now. We're going to move into a discussion among the presenters based on questions submitted. And I want to introduce some extra folks who are here to help the presenters, including Cassie Caravello with Texas Association of Community Health Centers, and Andrea Davis and Kelly Kasra, who both work with Sarah at Community University Healthcare Center. Thanks for joining us. So the first question I'm going to throw out there for the group is the following. Any recommendations or tips for decision support for teams that worked well? I believe I heard order sets and preference lists mentioned. Our team is considering the use of OPAs or our practice advisories to route people to the right follow-up step for an abnormal result.
Kelly, do you want to speak to our process for the abnormals?
Sure, yes. And I do want to say something that we are going to implement very soon is a smart phrase for providers for decision support. I think that's something that I wish we would have implemented earlier on. And I hope that that will help providers feel more supported when they're making decisions with a patient. Um, so at our clinic at Kook, abnormals, as Sarah said, would go to the RN team. And then we talk with our chief medical officer if we have any questions beyond our scope.
Okay. One of the questions that came in early was answered in the text, but I think it's a really valuable question to maybe call out for the entire group to talk about or hear about, and we can hear about the Minnesota and Texas experience. But it was, could you share strategies used to get provider buy-in? Dr. Halley, if you want to start and maybe rephrase, what answer you typed so folks are aware that you didn't have a lot of issue, but other groups may have.
Yeah, sure. No, I mean, I know this question, I always hear it come up and I'm just really curious about it because we didn't have any resistance. Like I mentioned, the opposite. People were kind of like jumping the gun and trying to do self-collect before we even, had rolled it out. So that said, we did do a lot of education. Like I mentioned, we did an all provider meeting and we really went over the evidence and, went over that like this is accepted by ASCCP, American Cancer Society, USPSTF, like everybody you could mention accepts self-collect as being one of the options. And that it's not actually new at all, that it's been offered, it's been approved by the World Health Organization since 2021. It's being offered in more than 20 countries, resource rich and resource poor. So I think people kind of were able to get on board knowing that.
If I may, I just wanted to chime in about that, I think looking at the organization's goals and trying to align with those and trying to align with some of the pressures that providers face can be really helpful too. Tying self-collect to our especially value-based care and kind of managed care HEDIS goals can be really helpful because providers might not have seen cervical cancer screening as like within their realm of control, and so didn't necessarily feel like they could be held accountable to that metric on their provider scorecard. But this is a kind of a new avenue to empower providers and care teams with the ability to like hit that metric today in the clinic where possible. So I guess I would just add that looking at it from that angle can get buy-in from other members of the C-suite, which then trickles over to more buy-in from providers.
I'm going to chime in on that as well, in that I feel like for Kook in particular, when we tied into this, we were really looking at our Somali speaking patient population and our barriers for collection for our population that had the least amount of cervical cancer screening, right? So we were looking at our vulnerable population that we're really seeing not significant numbers of test results coming through, and how do we make it so that we can remove those barriers for our patients to be able to get those necessary screeners completed. And so that also helped a lot with provider buy-in in that, like, where are vulnerable populations? What are those barriers for those populations? And a lot of our patients that have gone through significant sexual traumas, um, gender alignment, and the trauma with potentially needing to do a cervical cancer screening when we're transgendered populations, those kinds of barriers, those populations that are really vulnerable. Those were the ones that really helped to support the buy-in from the providers.
Okay, thank you. Someone just pointed out that there are so many exclusions involved in self-collection, wondering how much training or reinforcement did it require to train the rooming staff or the clinicians to apply self-collect, particularly as a standing order? And do you think the test might change with time to reduce that number of exclusion criteria?
We don't have it as a standing order. Like we've made it
Okay.
really clear. And actually some of our MAs have also jumped the gun, and I've had at least one where it's like the MA's like, oh, and they already went and did their self-collect. And I'm like, no, 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 no. That's not, yeah, that's not, you don't have to do that part. Like it is my job to talk with
Yep.
them about the different options and to make sure that they really are eligible and everything. But we tried to also just simplify. It looks really complicated, but it's really like, are you in the right have a recent history of abnormal, and are you bleeding heavily, or have some sort of like abnormal it's not as complicated, I think, as maybe it looks when you look at like the 10 different criteria.
That's good. One of the first questions that was accidentally put in the chat, but I'm going to share it anyway, is if HP only testing, including self-collected specimens, is becoming the standard, why is the ASCC recommendation that if you have an unsatisfactory PAP with a negative co-test, have to undergo repeat cytology, even if an FDA-approved lab platform was used with internal control? I was just going to quickly point out, because I was able to look this up during the question and answer period. Essentially, the 2019 guidelines from ASCCP state, although a negative HPV test performed from the same specimen as the PAP may be adequate for testing, even if the cytology is inadequate, interpreting that result in the setting of insufficient cellularity has not been validated, is kind of their point. I would encourage us to reach out, poke, ask more questions, and see if that can be changed. But John, I don't know if you have any other comments on that.
Yeah. So as Carolyn had mentioned, but there's differing guidelines between HRSA and the draft USPSTF at 5 years, and it's one of the preferred options versus secondary for ACS and ASCCP enduring guidelines. Really, they both did evidence reviews, and they reviewed different evidence. Their evidence wasn't exactly the same, and they came to different conclusions, is what it is. And so that's why there's a difference between the 5 year and the 3 year and different guideline recommendations. ACS and enduring guidelines use the same evidence base and if you look at the American Cancer Society guidelines, they concur with the enduring guidelines recommendation. And if you look at the HRSA and the USPSTF kind of aligns with their evidence selected and conclusions align more with other countries that do 5 year, like British Columbia or parts of Canada, and the Canadian Guideline Task Force and other international ones. And HRSA actually relied on the USPSTF if you look at the details, and also agreed with their interpretation. So that's why there's variation.
Thank you. I'm going to officially transition to Courtney as I need to run to another talk. Thank you. Don't leave yet. Courtney, you can take over from here for me. Thank you so much.
Okay. Can you all hear me? Okay. So I think we really have time just for one more question here. There is the question of, does anybody have experience with the Evelyn brush, using the Evelyn brush in this way? And I don't believe.
Oh, yes, I can speak to that. Kathy, well, not much to say about it, but patients find it highly acceptable. It's just as accurate, and it's an approved test. Mayo Clinics, it's too bad Kathy had to run off, but had to jump off. But Kathy McLaughlin is at Mayo Clinics, and that's what they've chosen as their device at Mayo Clinics. And I haven't heard anything differential between their experience and the other clinics that have used the Copan swab.
Okay. Since you're so quick, we'll go with one more. Just anybody can take it. Carolyn, I see you're typing out an answer, but can Sarah, Carolyn, you guys speak to patient uptake, and if you've observed whether there's any specific educational tools or strategies at the patient level that have been associated with completing versus not completing self-collect?
Yeah, I can talk. I mean, it's just been incredibly popular among patients, as you might imagine, if you've ever had to have a PAP yourself. Sorry, my dog is wanting to get involved in the discussion here. But probably our document that we have patients able to look at, while they're waiting for the provider, I think that probably helps. And again, I think it would be if you chose to try to explain to patients, so these two options, this is cervical collect is preferred, blah, blah, blah. I think that would make uptake more difficult and would honestly take just a lot more time out of the visit to try to explain all of those nuances, which is why we chose not to.
Great. Okay, well, we are coming up on time here, so I want to say thank you to all our panelists and to our attendees. We've had so many great questions that have come in. Any of that are left open, we will be sure to follow up with answers. I'll work with this great group to get answers to you. There will be a recording of this call available on the website, Roundtable website, in the next few days, and we'll also follow up with a link emailed out with the slides as well. Thank you so much for attending this. This is the last of our webinar series. It's been such a great success because all of you, these wonderful presenters and attendees. We encourage you to share the recordings and the slides. You can find the first and second webinar materials now at the link in the chat that Lily is going to drop in there for you. That has both 1 and 2, the slides and recordings. And then as we close out, we ask that you just take a moment to quickly fill out a quick 5-question evaluation of the session. And we hope you learned a lot of information that was not only insightful, but applicable to your work. So just thank you, and we hope you have a wonderful day.